So our next topic, advanced medications for Parkinson's disease, is co-presented by Dr. Bruno and Dr. Sarna. Dr. Bruno is a neurologist and movement disorder specialist in Calgary. She received her medical degree and neurology residency in Buenos Aires, Argentina. She completed her fellowship in movement disorders at the University of Toronto and a Master of Public Health degree at Harvard University. Dr. Bruno's primary interest is treating advanced Parkinson's disease, with a particular research interest in pain and other non-motor symptoms such as sexual dysfunction, depression, anxiety, and care partner health. Dr. Sarna is a neurologist in Calgary with a subspecialty in movement disorders. She obtained her Bachelor of Science with great distinction in biochemistry from the University of Lethbridge. She became involved in research in the undergraduate years and subsequently enrolled in the Leaders in Medicine combined MD-PhD program at the University of Calgary. She studied neurodegeneration in animal models, and after finishing her degrees, pursued a 5-year neurology residency at the University of Calgary. She was fascinated by movement disorders early on in her training, and following residency, completed her fellowship at the University of Calgary. Dr. Sarna is interested in all aspects of Parkinson's disease and prides herself in compassionate care of patients with the diagnosis through early to advanced stages. She's involved in clinical research, trials, as well as teaching both medical students and residents. I'd like to welcome Dr. Bruno and Dr. Sarna.
Thanks a lot, Charlene, and thank you for this invitation. It's always a pleasure for us to interact with all of you and have the opportunity to exchange information, because we think this is extremely important for you to learn more and more so you can make the best of your journey with Parkinson's. So the topic that we were asked to discuss today is about medications in advanced Parkinson's disease. And as mentioned, we will co-present with Dr. Sarna, as we both have different experiences and I hope things that you will enjoy learning about. I will start with a land acknowledgement. We would like to take this opportunity to acknowledge the traditional territories of the people of the Treaty 7 region in southern Alberta, and also the city of Calgary is home to the Métis Nation of Alberta Districts 5 and 6. And in this slide, I'm just showing my disclosures in terms of conflicts of interests. So what we will discuss today, we'll start with defining what are we talking about when we speak about what is advanced Parkinson's disease. And we'll put special emphasis in recognizing what are we talking about when we speak about motor fluctuations and dyskinesia. We will also talk about how we can optimize medications in advanced Parkinson's and what are the limitations that we face at these stages. And when is the time for advanced therapies? A very important topic that we will discuss in detail today. Dr. Sarna, who has a lot of experience in advanced therapies, will guide you through having more understanding on some of these therapies, such as intestinal levodopa infusion, and also some news about treatment that may be coming soon that you may have heard of, that is a subcutaneous levodopa infusion. And then we will discuss candidacy, so who may be a candidate and who may not, and why. By the end, we will have a discussion about what happens if I'm not a candidate for any of those therapies. Does that mean that there are no other options, or there's something else we can do? So just to start, when we discuss advanced Parkinson's, so what is advanced Parkinson's? So traditionally, we had a little scale that is called Hone and Yard that we use to try to define in which stage a patient with Parkinson's or a person living with Parkinson's was at. And that divides 5 different stages that start from the very first stage when symptoms are very mild and usually in only one side of the body, then progresses to 2 sides of the body, but with normal balance. It changes to stage 3 when balance starts to be a problem. And then when mobility becomes more challenging, we're in phase 4. And phase 5 basically speaks about a phase when the disease is very, very much advanced and mobility is very much reduced. So those concepts of disease progression and definition based on that scale are not completely wrong, but they're not completely accurate either, because we know that, as you have learned after some years in this journey, every patient may behave differently, and there are different experiences and different rates of progression. Not everybody goes through the stages in a very kind of classic way. So we're kind of changing in the field, the concepts. And so we know for sure that, and you all went through this, there are early stages when symptoms are very mild and limited, and you can manage them very well. Then there is an intermediate phase where we start to notice these, what we call motor fluctuations in dyskinesia. And then there is a more advanced stage when symptoms are more like clear and persistent throughout the day. That is a little bit later in the course of the disease. So we're moving from this classic little man that was the only drawing we had about Parkinson's to understand that Parkinson's affects many people, young people, older people, both genders, and people also from different places around the world. And that's why we need to learn more and more about it. In real life, basically what defines what's advanced Parkinson's and what helps us define treatment changes and the potential candidacy for an advanced therapy is the response to the treatment. So initially, when there are mild symptoms, you may have lived many years with some symptoms without treatment when things are very early and mild. Then we start treatment, and that's what we call the honeymoon phase, where, symptoms seem to respond very well to the levodopa particularly, and you are doing very well without complications. After that, there is some suboptimal control, and, the medication that was helping a lot helps, but for shorter periods of time, or maybe you start noticing that there are times during the day that you're much better and times during the day where you're not so well. And then we start really recognizing these motor fluctuations, these ups and downs throughout the day. Later, in this orange square, is when we have the fully established motor complications. And it's usually at that time when we start to make changes in medications. And then the advanced stage, when there are more of these motor complications associated with also an additional non-motor symptoms load. So we will discuss what we can do in these last 3 stages today. But just to close the concept of what does advanced Parkinson's mean, this will be different for each one of the individuals living with Parkinson's, because it will not just depend on medications and treatments and your symptoms. So for sure, we'll have a strong component of, the symptoms are progressing, so the tremor, the slowness, the stiffness, the balance are more pronounced than before. So I can say I'm in an advanced stage. But also it may be mostly related with non-motor symptoms starting to become more prominent, more sleep issues, more mood disturbances, like a bit more depression or a bit more anxiety. It can be mostly like constipation getting very challenging to treat, or some changes in memory and thinking. So there are other concepts, not just the tremor and the stiffness, that may help us define who is in an advanced stage of Parkinson's. The other very important concept is when the patient starts to feel, or when the person living with Parkinson's starts to feel that are losing their independency. So things that were very easy to perform, like feeding yourself, putting your clothes on, or going for a walk, are becoming more challenging, and you start to require more assistance. Another concept that really helps us is this that we will mention many times today about the medication. So I was taking my medication in time, everything was well. Well, now I'm starting to notice these changes. So that helps us also understand that we are switching into a new stage or phase of the disease. And then of course, the impact on your quality of life. So when you start to notice that your quality of life is not as good as it was a few years ago, and there are more social and emotional challenges when dealing with your Parkinson's symptoms, as well as more caregiver burden. So independently, all the three previous categories, at the point when you start feeling your quality of life is not as good as it was, is also a good marker for us to know, okay, things have progressed and we are more in an advanced stage right now. So as you heard, and you will hear many times today, a big part of this advanced Parkinson's or advanced therapies time is related with the presence of these changes that are called motor fluctuations and dyskinesia. And even if for some of you, this may be a very, very easy to understand concept because you may be experiencing it, many people living with Parkinson's do not really have that concept too clear. And sometimes your doctor may ask you, are you having any off time? How many hours are you in on time? And it's not a concept that anybody has explained. So you may feel, well, sometimes I feel off, but what does that really mean? Or when we ask about any flailing, like fidgety movements, what we call dyskinesia, sometimes it may be hard for people living with Parkinson's to differentiate that from what a tremor is. So yeah, I have some movements, but it's my tremor. Why are we calling it differently? So we thought it would be very important today to go through those two concepts because they are very important in order to understand what advanced therapies can provide in terms of benefit. A lot of these motor fluctuations and dyskinesia are related with the way the levodopa acts in the body and the blood concentrations that we reach throughout the day. So in this graphic, what you will see is what happens in the beginning of Parkinson's and then as the disease progresses. And basically, these are just levels of levodopa in the bloodstream and what happens. So by the time you just started having symptoms and your symptoms are very mild, you may have noticed that a little dose of levodopa would make a huge difference. This is likely related with the fact that even if there was a dopamine deficit, so the dopamine in your own brain was going down, there was some still dopamine left in some of the neurons. So that little dose of levodopa was supplementing that endogenous, what we call your own dopamine. So every time you took it, it reached a nice level in plasma in your blood, reach the brain, help, and stay very stable throughout the day. So probably for the first few years, there were not really changes. So I took my pills and I don't know if they are kicking in or wearing off because I'm just good throughout the day. But then as those dopamine levels of your own start going down, all these ups and downs start to occur. So what happens? So we start from a lower level of dopamine in our brain. So we take the pills. It takes some time for the pills to reach that concentration that is what we call therapeutic and helps. Then the pills start working and we feel better. But after a few hours, the effect starts to wear off. And then the next pill has to go through the same cycle once and again, dealing to this what we call off when there's no blood, no levodopa in your blood or your brain, and on times when you're feeling well because the levodopa is doing its job. Later in the course of the disease, or sometimes very closely together with the onset of the on and off times, you may notice that you still notice that the pills kick in, but after some time, they start to produce these movements that we call dyskinesia. This happens, we think, because that levodopa that you just took went through your gut, got to your liver, to your bloodstream, reached the brain, and went from nothing to a lot. And that may trigger some of these movements that we call dyskinesia. There are no tremors, because the tremors probably are gone by the time you take the levodopa, but there are these kind of fidgety movements that we will see in a second. Those concepts, on and off, and dyskinesia are extremely important for you to know and recognize because it helps a lot when you tell your doctor about those, understand how we can better improve, like optimize your treatment. So these motor fluctuations, just we will be slightly repetitive, but again, this is very important, are these ups and downs that involve these predictable or unpredictable changes in the motor symptoms. So for instance, you will see this gentleman here before taking his pills or in between pills. So he has very, very slow movements in their hands, and you will see throughout the video that he also has a tremor. So those moments when the pills are not really working are different from person to person. In some people, it may just mean a lot of tremor. And some people, it may mean no tremor at all, but it's very hard to move and I feel very stiff and sore. For other people, it may be just, I cannot really walk well because I'm very slow and stiff. So oftentimes are those like literally when the pills are not working and the symptoms are very, 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 very pronounced. For some people, that's predictable and it happens after each levodopa dose when they are wearing off after a few hours. For some other people, they may be unpredictable and appear in the middle of a dose, and there are different explanations for that. You see him here, it's very hard to stand up from the chair, and if I will move it a little bit so you can see how he can walk, but he walks very slowly and has this little stoop posture, while he also has a tremor. While on times are those times when the pills kick in and you say, okay, right now I know they kick in because I can move much better and my tremor is reduced. My walking is much better. Even my balance has improved. So the same person has just taken some medications to reduce the off symptoms of Parkinson's. And you will see soon that his facial expression changes. He can smile. His tremor starts to be reduced. And when we ask him to do the classic movements that we do in the clinic, he is much faster. And when I don't want to go too fast. So you can see his legs are also much faster. And when we ask him to stand up from the chair, he can do it in the first attempt. And his posture has improved. And his gait will also improve. So when we ask in the clinic, how are you having any off times? What we are really talking about are those hours or minutes in between tablets or any time during the day. Sometimes it's early morning before you take your first pills. Sometimes it's again later in the evening. Any time during the day when you feel your pills are not working and your symptoms are more pronounced. So with that concept, we'll jump to the next. That is the concept of dyskinesia. And dyskinesia are these kind of involuntary, abnormal, what we call choreiform movements that comes from the dance word in Greek, so where people like basically feel they cannot control movements that can happen in the neck, in the legs, in the arms, in the trunk, but are not the classic tremor that you have when you are off. And this can happen most of the cases as soon as the levodopa peaks. That means when it's working at its best. You will see people here with different dyskinesia. So you will see this gentleman, for instance, have movements in the trunk, a little bit in the hips. This person here has movement in the legs, and later some movements in the upper limbs. These are different from person to person. And what is very common is that the person living with Parkinson's themselves, they may not even notice that they are having dyskinesia. It may be more noticeable for the people that are around them, like their care partners or their family members. They said, oh, you're moving a lot. No, I'm not. Then it can become more evident for some people. But for most are not really bothersome or troublesome. So it's much better to have some dyskinesia than to be off and not being able to perform the activities that you want to perform. However, in a group of people, they can become what we call troublesome and interfere with your gait or when you're trying to eat or do things with your arms or with your head or with your arms. So those are another very important thing to know about because it will help you describe what's going on to your care providers. So what can we do when these things starts to happen? So levodopa will never stop working, just as a simple concept. It's the best treatment that we have and will always be helpful. But at one point, again, as your own dopamine levels go down, it may be important to increase the dose. And at one point, when we keep increasing the dose, we may face some complications. For instance, we may trigger more dyskinesias when we're trying to get rid of the off periods, or we may trigger some worsening in like confusion or drops in the blood pressure. So there is at one point, the classic question is, how much levodopa can I take? And the answer to that is as much as we don't have complications associated with it. But unfortunately, at one point, when we keep increasing it, we may face some of these complications. And then we have other medications that help. So some of you may be using some dopamine agonists as a patch or a little pill, like pramipexole, ropinirole, rotigotine. Some of you may be using rasagiline or seleshilin, or amantadine for the management of dyskinesia, or entacapone with each levodopa dose to make it last longer. And those can be used to try to improve these motor fluctuations. However, they are not free of complications. And unfortunately, as we get older, those complications are even more common. So we may try a dopamine agonist, but some people may experience low blood pressure or confusion or hallucinations or even sleep attacks or impulsiveness. We may try amantadine to reduce the dyskinesia, but some people feel that the brain is a bit foggy and they have some cognitive changes. So not perfect solutions. They can help, but sometimes even in advanced stages, sorry, I was. Were everybody listening to me? Okay.
We had lost you, but you're back now.
Okay, where was I? Did you listen to this first part?
Yes, I think you were at this slide.
I was saying we will adjust that to special symptoms and needs. For instance, we may put medications closer together, reduce the dose, increase the dose according to what may need. And we will basically try to do both, increase, reduce the dyskinesia and the motor fluctuations at the same time. Sometimes even we may recommend liquid formulations that sometimes a compound pharmacy can prepare, or even we can prepare at home by crushing pills and mixing with some water and vitamin C. However, those are not easy changes and they are not perfect. So you should not do them by yourself, and always discuss it with your neurologist or movement disorder specialist. So when it's time for these advanced therapies that you will learn a lot about today. So advanced therapies are options when those conventional medications do not longer provide an adequate symptom control and then are also affecting your quality of life. So when the motor fluctuations become prominent, when the on and off symptoms are disabling, when the dyskinesia impair functioning in everyday activities, and again, when the medications have been tried and nothing is really helping. So what are the options that we have in terms of advanced therapies? You probably heard a lot about deep brain stimulation. That is a surgical procedure, and we're not going to discuss that today because we will focus on medications. But there are all these infusion therapies that you may have heard or not about that are the focus of today's presentation. And they are levodopa intestinal gel or duodopa. Coming soon, hopefully, subcutaneous levodopa, and an apomorphine infusion that unfortunately is not available in Canada. So there are some considerations in terms of these advanced therapies before we jump in to describe them in detail. The first one is all of them require a specific assessment to see if the person that has Parkinson's is a candidate or not. And that requires a few steps to make sure we're not missing anything. Then, of course, we have to make sure that we have tried any medication change before jumping into something a little bit more invasive. And also we need to be very conscious of patients' preferences because some patients may not want to jump into an advanced therapy. The benefits of these advanced therapies are that they usually result in better symptom management and reduce the need of complex medication regimens. And also, in many of these, patients report an improvement in quality of life and more independence. However, we need to have some special considerations. So because these are a bit more invasive, for instance, DBS, that is a surgery, involves neurosurgical risks, and they're very mild or very minimal and not frequent, but they can occur. Also, it's not that you do it once and you never have to touch it again, but all these therapies usually require ongoing care and adjustments. And finally, these therapies overall target mostly the motor aspects, the tremor, the stiffness, the slowness. But sometimes some all other aspects, what we call non-motor of the disease, may not be significantly improved by advanced therapies. But Dr. Sarna will tell you more about that. The most important concept is that advanced therapies do not stop or modify the progression of the disease. So it's not a cure, it's not a slowing, it's just an improvement in symptom management. With that, I will leave space for Dr. Sarna to tell you more about the infusion therapies.
Thank you so much. I'm just going to put my slides on. I just want to double check that everyone can see my slides okay.
Yes, we can.
Perfect. Thank you very much for allowing me. Oh, this is going through. Just 1 second. Seem to be advancing without me trying. Anyways, thank you very much for allowing me to participate in this year's HOPE conference. It has been some time, and I certainly wish I would be able to see some of the familiar and unfamiliar faces in the audience. So as Dr. Bruno was saying, basically we will be reintroducing some of these concepts about why did medications used to work so well when I was initially diagnosed, and where do we go from here? And in terms of which part of your basically journey with Parkinson's we will be emphasizing on, it really is, sorry, just 1 second, I'm having some issues here. It really is, you know, the part of the disease where patients are experiencing these off-on phenomena, so the motor fluctuations. And it's something that really patients spend the majority of their time with Parkinson's in actually this stage of the disease. And I am glad that we are reviewing many of the concepts that sometimes when we see patients in follow-up seem unfamiliar. I will say that when patients first start treatment and we start asking about wearing off or dyskinesias, these concepts are very unfamiliar because at that point, actually patients are not noticing that they're fluctuating between an on or an optimal state versus an off state. But once they start fluctuating, they very quickly understand what we are asking them about. With my patients in clinic, I spend a lot of time drawing actually this, what I call this funnel with respect to disease progression. And so the blue part here is basically what we call the therapeutic window. And that is when your symptoms are ideally controlled on the medications. When you first start out and you're diagnosed, as Dr. Bruno was saying, you go through the honeymoon phase where even if you perhaps miss a dose or are significantly delayed, you don't actually notice that there's any deterioration in your motor symptoms. But eventually, usually the first thing that happens is that patients start to notice that there is some wearing off, and that where medications may have lasted for many, many hours, there is a deterioration in their motor response before the next dose is due. And that usually makes us adjust medications by either adding other classes of medications or potentially basically increasing the individual doses or compressing the intervals between the medications. And then as time goes on, many patients will also develop the threshold for dyskinesias, which are these involuntary movements. Most patients will have peak dose dyskinesias, and if they're relatively mild, they can actually function very well because they are in the on state during that time. But as you can see, with progression of time and as you lose that endogenous dopamine source in your own brain, you become more and more dependent on the exogenous source, which is, of course, your medications. And then this good window, this good on time, as we call it, becomes much, much more narrow. And patients fluctuate between the off state, which is your pink part here, as well as dyskinesias. I will tell you that sometimes I have patients that come into clinic and tell me that they see other peers at support groups, and those peers must be overusing medications because they have lots of dyskinesias. But really, for some patients, this window, this blue window, this therapeutic window can become so narrow that really patients oscillate between the off symptoms, which can be disabling, as well, and then dyskinesias, on state with dyskinesias. And so the concept of therapeutic window is really that good on time that will become more narrow over time. And as was indicated, we're dealing with a very heterogeneous condition. And obviously, everyone's progression into this narrowing therapeutic window will really be very, very different. Again, patients will oscillate between on and off states, and majority of patients will develop dyskinesias. It's something that we expect as part of the natural history of Parkinson's disease. Now, what makes things even more complicated is that these on and off states, when you take your medications, can also become less predictable over time, and they can become more severe and more abrupt. That's when patients may have difficulties actually planning for activities. Can I go to the grocery store, or will I become frozen and in the off state when I'm there, even though it's not going to be time for my next dose? And this leads to worsening of disability and declines in quality of life. And one of the most important messages that I also want to leave you with is that these off states actually consist of both motor as well as non-motor symptoms. So if you look at the therapeutic window, which is this kind of medium gray color here, as the medication goes from kind of low states when you're in the off state, and then through this good window and the supratherapeutic window, there's a number of symptoms that can happen. And we classically will talk about the motor symptoms that patients experience stiffness. Patients that have tremor may have worsening of tremor during that time, difficulties with movement. Then they transition to this good window. And then a lot of patients, if they're at the stage when they develop dyskinesias, will have dyskinesias. However, what we do not talk a lot about is that there's also a number of non-motor symptoms that can actually mirror the motor fluctuations. So when we take careful histories, we also notice that patients, when they're in the off state, may feel awful because they have terrible anxiety, or they may feel very low in their mood. They may have difficulties with their cognition during that time. And sometimes patients may even notice that they have more bladder symptoms or swallowing difficulties, excessive sweating, etc. Pain is another symptom that is very, very common in our patients. And again, that's something that sometimes can be non-motor fluctuation as well, that patients will develop worsening of pain when they're in their off symptoms. And then similarly, there are some patients when they are in their on dyskinesia state that actually may develop some other neuropsychiatric symptoms. Patients may feel very kind of high in terms of their mood. They may be more impulsive, more likely to take on risks that they wouldn't otherwise take on. And hallucinations is a symptom that really, while some patients may have it during kind of the on state, can be really present for some patients anywhere in the medication cycle. And so why does this change over time? So as we already discussed, as the disease progresses, there is a progressive degeneration of the neurons that make dopamine. So there's more and more of a dopaminergic deficit. And that the presynaptic neurons in the brain are now losing their ability to also store the medication, store the dopamine that you're receiving through medications, and release levodopa after it is converted to dopamine. And so essentially what happens is that the response to levodopa starts to mirror the short half-life of the medication itself. And what makes things even more complicated is that there is also variable absorption of oral levodopa because the medication may be delayed in how it's getting emptied from the stomach. The intestinal transit times are slowed. And as many of you may notice, when you have a meal, particularly a meal that has a lot of protein in it, that you may not get as much from that dose as you would otherwise. And lastly, because of hypersensitivity of the dopamine receptors, you also develop commonly levodopa-induced dyskinesias, again, typically at the peak doses of the medication. Yeah, 1 second here. And so why is continuous infusion of levodopa helpful for patients? Well, in a normal physiological state, people, all of us, have constant stimulation of dopamine receptors. And what happens with oral levodopa is, of course, you take a pill and there is a peak, and then there's a valley, peak, and a valley, etc. If that therapeutic window remains very large, patients will not notice that. But as that therapeutic window becomes smaller over time, patients notice the wearing off as well as dyskinesias. And what continuous drug delivery can do is basically, not in a straight line as illustrated here, but really can keep you much closer in that therapeutic window when your symptoms are well controlled. And device-aided therapies is something that we talk as physicians a lot about, but it's sometimes a concept that is not as familiar to patients. So device-aided therapy, or DATs, are really treatments that need to be considered when patients have suboptimal control of their symptoms, despite optimized oral medications. Some of you may have very, very complex medication schedules with multiple layered medications that are being given as often as every 2 hours. And despite that, you have difficulties with troublesome dyskinesias as well as debilitating off symptoms. And this is really when we need to consider device-aided therapies to complement treatment and minimize symptoms. As Dr. Bruno already reviewed, in terms of DATs that are currently available in Canada, we have deep brain stimulation options, which we will not focus on today. We also have levodopa, carbidopa, intestinal gel. Many of you may know this as duodopa, the trade name. And then what we are expecting to come out soon is a subcutaneous pump of fos-levodopa, fos-carbidopa, which I will briefly mention at the end. So what is LCAG, or duodopa? It actually has been available in Canada since 2014, and some of the Canadian clinical trials were basically completed a couple of years before that. It is available only at subspecialized movement disorder centers, so not something that you will find in general neurology clinic. And in terms of our team here at the Calgary Movement Disorders Clinic, it consists of myself, Eric C., who some of you may know through the Calgary Clinic, 2 gastroenterologists, Dr. Andrews and Dr. Turbide, as well as a radiologist that is able to help us with tube placement through basically radiological interventional methods. Who is eligible for LCAG or duodopa? Well, of course, you require diagnosis of Parkinson's disease because we are targeting levodopa responsive symptoms. You need to be optimized on oral medications. You need to be tried on all classes of Parkinson's medications to make sure that there isn't something that has been left out or overlooked. And this is a therapy that is approved for patients that have 25% of off time during their waking hours and or have troublesome dyskinesias. Severe dementia or psychosis is a contraindication, but patients can certainly have some degree of cognitive impairment and still benefit from this therapy. And they also need to not have gastroenterological contraindications, meaning that the gastroenterologist needs to be able to put the PEG-G tube in order for this therapy to be started. And most importantly, there's absolutely no age limit to this treatment as well. In terms of example of medication schedule that of a patient that may be a suitable candidate, I will just walk you through, which I would say in our clinic is a relatively simple medication schedule. So this theoretical patient is taking Sinemet, so levodopa, carbidopa, 2 tablets every 3 hours. They're also taking entacapone with each dose, and they are also on amantadine because they have dyskinesias. And this patient tells us that they're wearing off 30 minutes before each dose of medication. Then unfortunately, next dose is taking 30 to 45 minutes. So we have at least 1 hour of off time with each of these medication intervals. That higher doses that we previously tried resulted in troublesome dyskinesias. That tells us that if we go higher, we're just going to be dealing with additional issues. And that during off time, this patient is actually pausing their activities and they have difficulties with functioning. One of the things that's also very difficult to overcome with oral medications is when patients tell us that they do have dose failures. There are some doses that are taken and produce absolutely no relief in symptoms, because that will be really difficult to overcome by basically changing the timing of medications. Components of LCIG basically include, you can see here, the pump itself, the LCIG cassettes that contains medication. We will review that shortly. The PEG tube, which basically goes into the stomach, as well as the intestinal tube. Because what makes this therapy effective is the fact that we are bypassing the stomach and that the medication is actually delivered where it needs to be absorbed. If we were infusing levodopa straight into the stomach, we would have the same issues as you have with your oral medications, that the medication may just be sitting there and it's not getting where it needs to go in order to become absorbed. So some basic principles, just a little depiction of the pump itself here. For most patients, LCIG would be typically used for 16 hours per day. And so that would be your waking hours, and that we would be switching to oral medications for use overnight. Each of the cassettes that you have would basically be equivalent to 20 tablets of levodopa carbidopa, so 20 of the yellow tablets that most of you are probably on. And that really just gives us the potential dosage. Patients can be on 800 or 1000, or some patients actually may be on more than the equivalent of 20 tablets during the waking hours if they have higher levodopa requirements. Morning dose is used basically to establish the on response upon awakening. And then we keep patients with a continuous dose that is infused with really programmed and customized doses that are suited to your symptoms to maintain you as close to the on response as possible throughout the day. And then extra doses can be administered to treat off symptoms, or for some patients before exercising or before social engagements, they may wish to basically give themselves a little bit of a boost. And lastly, the pump can always be paused if dyskinesias are an issue or disconnected for showers or other activities. And so, again, why does continuous levodopa improve motor and non-motor fluctuations? Well, we're, again, infusing levodopa carbidopa directly into the upper jejunum. We are bypassing the stomach, and we have a continuous levodopa delivery with customized doses that are really suited to your symptoms to keep you as close as possible to this therapeutic window. And what we really expect to this therapy is that we would have reductions in the off time, meaning the time that is spent here, as well as reductions in dyskinesias in most patients. Who is eligible for LCIG or duodopa? So again, 25% of off time during the waking hours and or troublesome dyskinesias on patients that are optimized on medications. Any disease duration, so you don't have to have the disease for 5 years or 10 years. Any age, no restriction there. Patients that have mild cognitive impairment can certainly be considered for this. Patients that are in long-term care can also be considered for this. And I should say as well, for those of you that may not have a care partner, that is also not a contraindication, although it is very helpful to have someone that would be able to help you if needed. And will LCIG improve all of my symptoms? So what I really wanted to emphasize is that really this is a unique way of delivering the medications, but that ultimately we are still using levodopa, carbidopa, which is our gold standard. And what we are expecting to improve are really levodopa responsive motor and non-motor symptoms, and not other symptoms. And as the disease progresses, patients may also develop some symptoms that actually do not respond to the tablets. For some patients, the classical example of that is freezing of gait, which some of you may experience, whether you're in the on state or whether you're in the off state. And so if it's one of those symptoms that is present in both of your on time and off time, that's something that may not respond to basically to this, because it's the same thing as the tablets. And then, as Dr. Bruno already indicated, this is a medication. It's the medication that you all know very, very well. You know that it helps you, but it's not expected to be disease modifying, i.e., it does not change how the disease itself progresses over time. And then how much improvement can I expect from LCIG, from DUODOPA? Well, we have studies to support the fact that there is a significant improvement in on time without dyskinesias and reduced off time when you compare it to patients that are optimized on oral medications. And similarly, there's also significant improvements in quality of life measures, and actually also in quality of life of caregivers. Lastly, LCIG is something that can be used safely for years with sustained benefit. And how do I get referred for LCIG? So I cannot speak to Northern Alberta, but certainly for our catchment area, if you're a patient at the general neurology clinic, you will need to get referred to the movement disorders clinic for a DUODOPA assessment. And if you're already a patient at the Calgary Movement Disorders Clinic, your neurologist can initiate the referral directly. The way that we have the patient flow organized is to really have LCIG education first and foremost, because some patients may be very wary, may be very hesitant to consider this form of treatment. And we find that if patients have an opportunity to discuss things with the nurse, actually see the pump, potentially wear the pump, ask questions, they may be much more likely to consider this treatment. And so most patients would first actually meet with Eric, our DUODOPA nurse. And then unless you're my patient already, you would see me so that we would review eligibility for this treatment, goals of treatment, make sure that the expectations that you have from the treatment are realistic, and that we are both on the same page in terms of symptoms that may improve and also symptoms that may potentially not improve. Lastly, we would also determine whether doing a nasojejunal tube insertion trial is indicated. And this basically gives us a way to just do a temporary tube that goes from the nose to the jejunum, and we can try the pump without actually the procedure itself. If patients proceed through those stages, then they would see the gastroenterologist, they would proceed with the PEG-J tube placement, and then we'd basically go on to optimizing your doses and titrating. Patients that are on LCIG will continue to receive follow-up from Eric and myself, and so there's ongoing dose adjustments as required. We monitor patients' weight, vitamin levels, symptoms of neuropathy, and you really would be involved in multidisciplinary clinic appointments that involve nursing, neurology, and also for some patients, neuropsychiatry if needed. You would also continue to follow with gastroenterologist and have tube replacements every 2 years or sometimes a little bit longer. And so lastly, are other device-aided therapies available? And as Dr. Bruno was already saying, we are expecting a very exciting treatment to be available on the horizon. That is the subcutaneous foslevodopa foscarbidopa pump. Phospholevodopa phoscarbidopa is basically a prodrug of levodopa and carbidopa, so it very quickly gets converted to levodopa and carbidopa, who you all know well. We had the fortune of actually being able to participate in the clinical trial of this product here in Calgary, and the medication itself has now been approved in Canada, and approval of the pump itself is currently pending. The exact availability in Canada is currently unknown, but hopefully once we know more, we can provide you with additional information. So what do we know right now about this product? Well, it actually will be a 24-hour infusion. So not just 16, but really for the whole day as well as the whole night. The medication will be infused subcutaneously, so just right under the skin. That means that there's no surgery required, there's no procedure required, and the pump will actually have the option of 3 different infusion doses, the option of giving extra doses, and of course the option of pausing and disconnecting the pump. The doses will be customized to your symptoms and to your levodopa requirements, and it still remains to be seen what the eligibility criteria for this particular product will be. There is 2 main clinical trial data publications that have been published with this product. And we know from these 2 publications that patients have a significant increase in on time without troublesome dyskinesias, that they have a reduction in off time, and that the proportion of patients that receive monotherapy, i.e. a single medication, meaning just the pump itself, also increases over the course of the study, and patients have much improved symptoms first thing in the morning. I will now hand it over to Dr. Bruno to wrap up.
Sorry. Hello, can you hear me?
Yes, we can hear you. I just wasn't sure if you were finished and we could start with questions, or you had.
I'm not. I just something happened, very strange happened here with my computer. Nothing is working. Okay, let me try once again. Almost there. It just doesn't open anything. I am sorry, the modern world is killing me. You know what? I will leave it without slides because I don't want to make anybody wait and my PowerPoint collapse. I'm sorry about that. So after everything you have heard, and I really apologize, I don't know what happened. A question that comes to us a lot of times is, okay, can I be a candidate for these therapies? And then sometimes the questions may be a yes, and sometimes it may be no, and that may have multiple different answers. So one of those answers may be, well, maybe it's too early and we still have other things to try first. It may be just a little bit too late and complications or risks may outweigh the benefits from these advanced therapies. And sometimes it comes from the other side and is, no, we really, as a patient, as a person living with Parkinson's, I don't want to go through a more invasive therapy. I want to stay as I am and maybe improve other aspects. So not being a candidate for an advanced therapy doesn't necessarily mean that there's nothing else that can be done and now you're discharged and you don't need to see us anymore. There are a lot of things that we can do at that stage still that you need to be aware of, so you can ask about and work with your team about those. So a lot of it, as I mentioned, it may be changing medications, adding additional medications, changing timings. A lot is related with some questions that we had, increasing more exercise to make the effects even longer and more beneficial and feel a bit less stiff. Physiotherapy that is helpful in many cases, occupational therapies that is also super helpful sometimes. Speech therapies, if speech is one of the important aspects of your symptoms, but also improving more than ever the management of the other symptoms that we have mentioned many times today that are the non-motor aspects. You know, sometimes people are fluctuating up and down, or they say my pills didn't kick in, and then they're maybe having a bowel movement every 7 days. And then after we manage constipation, the levodopa is much better absorbed and the fluctuations are reduced. Similar things with like improving sleep, so you are less fatigued during the day, and maybe your motor symptoms are even much better. So improving the non-motor management in parallel with improving the motor management, as much non-pharmacological support as we can get. And also being very much aware of all the other dimensions that may be affected in those stages by Parkinson's. And then focus on emotional health, social support, like caregiver care, and then all together, what we call in a multidisciplinary way approach, we can tackle all these things and make things better for you, even if an advanced therapy is not an option. So with that, I had a very nice thank you slide. We're very grateful for being here, and we apologize for all the catastrophes in terms of technology, but I hope you could get most of it, and I hope it was useful. And both Dr. Sarna and me are happy to answer any questions.
Thank you very much, Dr. Bruno and Dr. Sarna. We do have a number of questions. So I have a question. How does exercise affect the fluctuations in the medication cycle?
That's a great question. I will start with that. And I will start with that because recently I saw one of my very active patients, and basically she was going to exercise without taking her pills because I think she read that that would basically use all of it while exercising, so she will not have enough for the rest of the day. And that's a bit of a misleading concept because it's not a straight line that we take the pills and if we do more activity, we use more or less. But on the opposite side, if you go to your gym class off, it may be very challenging to move around and you may hurt yourself and then not being able to exercise for a long time. So in my experience, it's better to take your pills, go to exercise in a good on time. So you are at the best of your movements, you can get the most of it. And the effects of exercise on Parkinson's are not a short-term effect only because you may feel more invigorated by the end, but it's a sustained accumulative effect that not only helps. It seems to be the only thing that right now helps reduce the progression of the disease a little bit, but also reduce the risk of developing some of the cognitive or mood changes that happen with the disease sometimes. So I would say it doesn't really affect the medication. The exercise doesn't affect the medication. The exercise affects the disease. And the medication affects the exercise. So I would go to exercise when I'm feeling at my best because that's when you can do more. And the more you can do, the better you will do in the future too.
Thank you. One of the questions was, if a patient has an infusion, are they able to exercise? And I do believe you've answered that there's no restrictions, correct?
That's correct, absolutely. And in fact, we would hope that patients can exercise even more and better than on oral medications. And to add to Dr. Bruno's point, I also very much encourage patients to be in their optimal on window when they are exercising. They will enjoy it more. They are much more likely to engage in physical activity, which will be good overall. But I should say too that patients that are on LCAG and patients that we have seen through the subcutaneous levodopa, phosphocarbidopa pump do actually benefit from using an extra dose in anticipation of exercise. And I suspect that probably the higher infusion rates that we will have on this new pump will also be very helpful to either do an extra dose or to switch to a slightly higher rate when you are exercising.
I have another question. I have children that are in their 30s. What is the risk of them becoming diagnosed with Parkinson's? Can they be treated for, sorry, can they be tested for biomarkers?
I don't know who wants to go first. I can
You can
certainly
take
give it. So that is really variable, and it depends on whether their parent has a genetic form of Parkinson's disease. There are some genetic forms that increase the risk, and there are some genetic forms that actually have different mode of inheritance. So it's actually a very complex questions. What our current genetic testing is not good at is looking at many different genetic components that may be increasing the risk. And basically at that, like with that sort of situation, patients cannot have predictive testing. And so I think that would only apply to a very tiny portion of our patients where their children may have the ability at this point to be tested for something in a predictive way.
I have another question. The new subcutaneous therapy, how is it inserted if it's not a surgical procedure?
So basically, I don't know if any of you are familiar with insulin pumps, but it uses the same kind of technology. There is a little mechanism that basically inserts a tiny little needle and then leaves a cannula under the skin. There's two different cannula lengths, 6 millimeters and 9 millimeters. And then basically the cannula stays under the skin, and that site only needs to be changed like basically every 3 days. And that's how the medication is delivered. And then you change the sites where you basically apply this. So it's something that you would do by yourself at home. And because it's 24 hours, presumably also your symptoms would be so well controlled first thing in the morning that you actually would have kind of the best dexterity that you can. And there would be no procedure. It's something that you would be doing absolutely by yourself. With training, of course.
If someone is on current duodopa therapy, would they be able to switch to the new subcutaneous therapy?
So I certainly am telling all of my patients that are on duodopa that I hope that it's something that we can try and see whether this new product will serve them better than duodopa itself. Because again, most of our patients on LCAG are actually on 16 hours. We do have occasional patients that require 24 hours. So that is my hope. And really for most patients, what I would say is that we probably would try to, if we can try it and if we can get proper reimbursement, because we don't know yet how that's going to work, that I would encourage them to really leave the PEG-G tube kind of intact until we really give this new product a good try, so that if it's not working as well for them as the current therapy, that we don't have to do another procedure. But yes, in short, I really hope to try it in any patient that is interested.
I have another question. Someone is taking their levodopa and they find that their tremor increases, weakness is worse, emotionally they seem to be worse. Is this a side effect of their medication?
I can take that one. So this is a very interesting question. Thank you for bringing it, because you probably read and hear saying levodopa will make your symptoms better, and that happens in most of the, I would say 95% of patients. But there is a group of patients that when they take the levodopa do not feel great, particularly in the very beginning. So that latency until it starts working can be tricky for a lot of people. It can even make the symptoms worse, and we don't understand exactly why, because it only happens in a small proportion of patients. It can make people feel very agitated.
I think Dr. Bruno is frozen.
Okay, maybe I will take over. I agree with everything that she has said. I guess the one thing that on history I always need to determine as well is whether the reason why someone feels worse right after they take the medication is because they're actually wearing off from the previous dose. And so that's something that can also happen, right? Like, I feel so much worse after I take the medication, except like an hour later, they feel better because now that medication has kicked in. So that's something that also on history, we try to kind of sort out to make sure that that is not part of the wearing off from the previous dose before this dose actually had a chance to get absorbed.
Yeah. And the other thing, sorry, I'm back, I think. The other thing that I don't know what's going on. The other thing that may happen is that, sometimes people take the levodopa, and if they have a predisposition, it may drop the blood pressure, and that may make you feel agitated or like more shaky. So there are a lot of things. It's very important to discuss this aspect because there are a lot of things we can do, maybe a lower dose a bit closer together, or use some medications that will reduce some of those additional effects of levodopa if it's not making you feel well. But overall, most of people with time get
Dr. Sarna, maybe you can answer this question. Can too much levodopa contribute to dementia?
So certainly levodopa can have cognitive side effects. And sometimes if we are hitting that point where patients are having a lot of hallucinations and are having a more vulnerable brain
to those effects, and then they disappear, and then they just feel the...
You were frozen. Oh, we lost her. Anyway, so at some point, for some patients, there may be changes in thinking and memory, and there may be hallucinations. And certainly hallucinations is something that can be a dose-dependent side effect. And at some point in the disease journey, we may actually want to simplify the medication regime by taking away some of the medications that also have a higher risk of hallucinations and cognitive side effects. At some point, patients may be just on levodopa monotherapy, meaning just levodopa and nothing else. And in some cases, as the disease progresses, we may actually need to start reducing the medications to really overcome the side effects that at that point in the disease process, levodopa is producing. But it's not that levodopa itself causes the cognitive changes. It's that levodopa at more advanced stages of disease can give rise to more of these cognitive side effects. And we need to basically simplify the medication regime.
How does the physician decide which advanced therapy would be recommended?
So when I see patients and I see that we're starting to struggle with, first of all, a complex medication schedule, but in addition to that, worsening of off time, worsening of troublesome dyskinesias, we will really discuss all device-aided therapies on the table. However, if someone basically is on, 70 and over or mid-70s, we really would discuss that while DBS is a device-aided therapy, it's something that really may not be for them, because with that option, which we did not really spend much time talking about today, that is something that is really not an option for patients that are, for example, in their late 70s or beyond. So we discuss all options and then basically say, we can't really consider that. Age is not really criteria for LCAG duodopa, so that can be considered in any patient. And what I would say is that because deep brain stimulation surgery is something that is quite portable and does not require a lot of the everyday and is quite suitable for younger patients, is that it really is, for most patients that are younger, a suitable device-aided therapy. But as Dr. Bruno indicated, we also need to respect patient preferences. Some patients may never wish to undergo surgery, or some patients may simply require a little bit of time to warm up to the idea of potentially having DBS. And, I would expect that potentially this new subcutaneous foslevodopa, foscarbidopa pump may also be a treatment for some of the patients that are struggling with fluctuations, are younger, but are just not willing to consider the option of surgery at that point.
There is a question from a person. Is there any challenges with the pump and intimacy?
So I guess I will speak to LCIG first. And I must also admit that it's something that we really should spend a lot more time talking about. And sometimes it's something that we actually are relying on our patients to bring to the table, because we don't want some of those questions to feel intrusive. However, I will say that with LCIG, you have the option, just as you disconnect from the shower, to also disconnect from the pump. Some patients may have some, potentially self-image issues by having the PEG-J, but at the very least, it's something that they can disconnect from, give themselves an extra dose, an extra boost, and can hopefully share some intimacy with their partner. Similarly, with the subcutaneous foslevodopa, foscarbidopa, gives you the same option. You can disconnect from the pump, potentially give an extra dose before you disconnect, and so you can be kind of, I will say, unattached to something, and hopefully engage with some intimacy that way as well. But I hope, I know if all my patients are listening, please discuss this and bring this to the table. But it's something that absolutely we should be talking a lot more about.
I have a question also. It says it was recommended to take medications with vitamin C. Should we also be taking vitamin B12? And if so, what is the recommended dose?
I don't know, is that coming from when I said the liquid formulation, or someone got that recommendation? So vitamins and Parkinson's are a very interesting topic, and it's kind of hot these days because there have been some new like mass diffusion articles about vitamin B1, B6, B12, magnesium, and different formulations. I think it's always good to chat with your doctor. There's no formula. It's not a straight line. Not every single patient may need vitamin supplementation, and it will not cure or stop the disease for what the knowledge that we have nowadays. But some patients may need supplementation to reduce some potential side effects of medications, or because they have a deficit in vitamin B12. I think that's something that you can discuss with your family physician and your neurologist, but there's no rule like every single patient with Parkinson's needs these supplements and these vitamins. So I would not worry too much about that, but yes, discuss it with your doctors in case you have a need to supplement any of those.
I have a question. Botox has been suggested to control tremors. Is this something that you would recommend?
I don't think I heard what was the first part of the question.
Botox has been recommended for tremors.
Oh, I will let Dr. Bruno answer this.
Well, Dr. Sarna said that because I really like Botox for many, like botulinum toxins, for many different uses in Parkinson's. But tremor is a tricky one because tremor in the hands is related with the activation of very little muscles. And the reason you want to avoid tremor is because you want to have function in those hands. So you want to do your stuff without tremors. If we inject the muscles to the point that we put a dose that we know will reduce tremors, it may make your muscles too weak, because it's a muscle relaxant, to the point that you cannot use your hands or your fingers as you want to use them. So it's tricky, and there are people that may require that if they have tried everything else available and it didn't work. But it needs to be done by someone with a lot of experience, usually guided by electromyogram or by ultrasound, and it needs to be done with the knowledge that basically if the muscles get too relaxed, you may be weak for a few days or for a few weeks. So it's not ideal, and that's why we may use it more in other types of tremor because there are not many options, but in Parkinson's, because we have other options, we may leave it as the very, very last one.
what are your thoughts on stem cell transplant as treatment?
I see you muted yourself. That's a hard one. And I think it's something that a lot of our patients ask us about quite a bit. I would say that it's still an area of research that is ongoing. But at this point, it's not something that I think is entering a lot of kind of mainstream treatments. But not an area that has been abandoned by any means. And I think a lot of our patients really are hoping for that game changer treatment that will actually alter the course of the disease. And of course, that is what the promise of stem cell research is all about. How do we actually have, dopaminergic brain cells that will be able to make the dopamine that you're no longer able to make enough of? I don't know if you have something else to add to it. I don't know if Dr. Bruno's frozen again.
I think she's frozen again. There is a question about how much the pump costs.
We don't have that information right now. Yeah.
Okay, there is another question about how do you decide between DBS, Duodopa, and potentially the new subcutaneous therapy?
Okay, so I think it probably overlaps a little bit with the answer that I gave kind of a few minutes ago, but I would say the first decision point is really age. So is DBS an option for you because of your age? And also I should actually add, because of cognition. Sometimes patients can meet the age criteria, but because their cognitive function is such that it may predispose them to more potential complications from cognitive perspective, DBS also may not be an option for that reason. And so those are really the two criteria that we would use first to see whether DBS is an option for a patient. And then really at this point, I mean, we only have LCAG or Duodopa, and it remains to be seen what exactly will be the eligibility criteria for subcutaneous pump in order for that treatment to be approved for our patients. So at this point, we're not sure yet, how many hours of off time patients need to have. I would presume that for that new treatment, we will also need to have patients tried on all medications, make sure everything is optimized before we would consider that. But, the difference between LCIG versus the new subcutaneous pump, I think there's going to be tons of overlap. And LCAG is not going away. It will still be there, but I suspect that a lot of patients will consider this option without a procedure or surgery first before they would consider LCIG. And then really it comes down to preference as well, I think. I suspect that we will have insurance coverage for patients that respects their individual choice and what will be right for them. So even if they are eligible for DBS, I would hope that their own preference, if they want to either delay it or forego surgical options, that we will be able to provide this new treatment to patients that are also DBS eligible.